All right, diving in today, folks. We're going deep on something pretty vital, especially for all the future nurses out there and those teaching them. We're talking about how nurses handle labor and birth. I mean, this is intense stuff, right?
Oh, for sure. This is where the rubber meets the road.
Yeah.
So what we really want to do today is zoom in on the core stuff nurses need to know when a person's going through labor and birth. Think assessments, comfort, and pain management.
Yeah, the essentials, the must-knows, all that good stuff. And we're pulling this from some serious sources here, the kind of textbook stuff that's packed with info. But, we want to make this lively, something you can actually use.
Absolutely. We want everyone listening to walk away with a much clearer idea of what nurses are responsible for during this big event, like the key assessments we do and the different ways we can help make someone more comfortable and manage pain. It's all about being practical and useful.
Okay, so let's break it down, starting with how do we even begin assessing the person in labor? It's not just a quick once-over, is it?
Definitely not. Assessing the mother during labor and birth, it's a continuous thing. We're always checking on her, how she's responding to the labor, how things are progressing. It's like watching a story unfold in real time.
And what are some of those vital signs that kind of give us a glimpse into that story?
Well, you've got your basics, right? Temperature, blood pressure, pulse, respiration, decising. We're checking those all the time. And then, of course, we're also focused on the person's pain level. That's huge. But beyond those immediate numbers, we need to look back at her prenatal history, too. Things that might have affected how well the placenta was working during pregnancy, those can impact the baby's oxygen supply during labor. Like if she had high blood pressure before, that's something we'd definitely be keeping an eye on.
Makes total sense. Got to know the starting point to understand what might be happening now.
Here.
Now, vaginal exams. I feel like that's a topic that can raise some questions.
Yeah, definitely. I mean, vaginal exams are invasive, and for a lot of people, they can be pretty uncomfortable. So it's super important that we, as nurses, only do them if there's a clear reason, We have to make sure the information we get is going to actually help us take care of the person better.
So it's not just like a routine thing we do every few hours, no matter what's going on.
No, not at all. We always have to explain to the person in labor and their partner, hey, this is why we think a vaginal exam is important right now. This is the specific info we're hoping to get. And of course, through the whole thing, we're doing everything we can to make sure it's as private and respectful as possible.
And what exactly are we looking for during a vaginal exam?
So we're checking on several things to see how labor is progressing. First, there's cervical dilation. That's how much the cervix is open, and we measure that in centimeters. Then we've got cervical effacement, which is how much the cervix has thinned out. We usually describe that as a percentage. We also need to figure out what part of the baby is coming first. Is it the head or maybe the breech? That's the fetal presenting part. And the fetal position tells us how that presenting part is lined up with the mom's pelvis. Like, is the back of the baby's head facing towards the front? Then we've got fetal station, which tells us how far down the baby has moved in the pelvis. We measure that in relation to these bony landmarks called the ischial spines, and it goes from -5, meaning high up, to +4, meaning really low. Sometimes we might see some molding, which is when the baby's head changes shape a bit as it moves down. It's temporary, though. And lastly, we check the amniotic membranes. Are they still intact, bulging, or have they ruptured?
Wow, that's a lot of info from one exam. So what happens with all those findings?
Well, we need to talk about them clearly and openly with the laboring person and their partner. We explain what we found and what it means for the plan of care going forward. And of course, we're documenting everything very carefully and letting the doctor or midwife know.
All right, let's switch gears a bit. What about when the water breaks? When the membranes rupture, what's the first thing a nurse does?
Okay, so that's a really important moment. The absolute top priority when the membranes rupture is checking the baby's heart rate right away. We're listening super carefully for any decelerations, which could mean there's a problem, like the umbilical cord is getting compressed, or maybe even a prolapsed cord.
So fetal heart rate, that's the big thing. What else do we check when the water breaks?
We make sure to write down the exact time it happened, plus the color of the fluid, how much there was, and if we notice any odor. To be sure it's actually amniotic fluid, we'll usually do a nitrazine test. Basically, amniotic fluid is more alkaline than what's normally in the vagina, so it turns a special swab, this blue-green color, sometimes a really deep blue, and that means the pH is somewhere between 6.5 and 7.5. Regular vaginal fluid is more acidic, so the swab stays yellowish or kind of olive green, with a pH around 5 to 6. Now, just a heads up, if there's a lot of blood, it can mess with the nitrazine test a bit and give a false positive because blood is alkaline too. There are also these newer bedside tests that can detect specific proteins found in amniotic fluid, but we always put those results together with everything else we're seeing.
And when is it so important to get the exact time of the rupture?
Well, the longer those membranes have been ruptured, the higher the chance of infection, both for the mom and the baby. So we're watching for things like a fever in the mom, a faster heart rate in either the mom or baby, any funky smell from the vaginal discharge, and an increase in the mom's white blood cell count.
Okay, let's talk about what gets labor going, those uterine contractions.
Right, the powerhouse of labor. Uterine contractions, that's what really makes things happen. They create pressure inside the uterus, which helps the cervix open up, thin out, and eventually it helps the baby move down the birth canal. We talk about contractions in terms of their frequency. That's how often they're happening, measured from the beginning of one to the beginning of the next. Then there's duration. That's how long each contraction lasts. And we've also got intensity, which means how strong the contraction is at its peak. And last, there's resting tone, how tense the uterine muscle is between contractions.
How do we actually keep track of all those different aspects of contractions?
We use a couple of different methods. One is just feeling, palpating the top of the uterus, the fundus. We use our fingertips to feel how tight the muscle is and to get a sense of the intensity. You get pretty good at telling if it's mild, like feeling the tip of your nose, moderate, more like your chin, or strong, like feeling your forehead. The other way is using electronic monitoring. We'll put a tocotransducer on the mom's belly, and it picks up on the pressure changes from the contractions. And we usually have another sensor that uses ultrasound to monitor the baby's heart rate at the same time.
And what do those measurements tell us about how labor is going?
So usually contractions have to be around 30 millimeters of mercury or stronger to really start making the cervix dilate. As labor gets more active, the intensity goes up, often somewhere between 50 and 80 millimeters of mercury. The resting tone is important too. Early on, it's pretty low, around 5 to 10 millimeters of mercury. But as labor progresses, it might go up a little to like 12 to 18. We want to make sure the uterus is relaxing between those contractions.
You also mentioned something called Leopold maneuvers. What's that all about?
Leopold maneuvers, it's basically 4 different ways we position our hands on the mom's belly to feel where the baby is. They help us figure out the baby's lie, meaning, is the baby lying up and down or more sideways? We can also tell what part is coming first, head or bottom, and how the baby is positioned in relation to the mom's pelvis. This helps us find the best spot to listen to the baby's heartbeat and also get an idea of how far down the baby's head is. Like, if we can easily touch our hands together above the mom's pubic bone, it probably means the baby's head isn't fully engaged in the pelvis yet. If we feel resistance, like our hands can't quite meet, that's a good sign the head is engaged.
So we've covered assessing the mom pretty thoroughly. Now let's switch over to the baby fetal assessment during labor and birth.
Yeah, fetal assessment, it's all about making sure the baby is handling labor okay. We definitely pay attention to things like the amniotic fluid, but the most important thing is analyzing the baby's heart rate pattern. Sometimes, after the baby's born, we'll analyze blood from the umbilical cord, or during labor, we might do fetal scalp stimulation if we need more info about how the baby's doing.
So the baby's heart rate pattern is like the main signal for how they're coping.
Exactly. It gives us a peek into the baby's oxygen levels. We can monitor it just every so often using a fetoscope or Doppler, or continuously with electronic fetal monitoring, which can be either external or internal.
What's the main goal of doing all this fetal monitoring?
The big picture goal is to avoid any bad outcomes, like preventing the baby from dying or having serious problems by catching any signs of distress early enough to do something about it. That might mean addressing whatever's causing the problem or making sure the baby is delivered safely and quickly before anything bad happens.
There's been some debate about using intermittent listening versus continuous monitoring. Can you clear that up?
Yeah, so continuous monitoring, what we call EFM, does tend to find those abnormal heart rate patterns more often and sometimes earlier than just listening intermittently. But the interesting thing is studies haven't really shown a difference in bad outcomes for babies in low-risk pregnancies between the two methods. What they have found is that continuous EFM seems to be linked to more C-sections.
So it's not like continuous is automatically the better choice for everyone.
Right. For people with low-risk pregnancies, intermittent auscultation is totally fine and often even preferable. It lets the laboring person move around more freely, and it can make that nurse-patient connection stronger. Nurses have a big role to play in explaining the options and advocating for intermittent auscultation when it makes sense. But of course, if there are risk factors or we're using meds to speed up labor like oxytocin, then continuous EFM is generally recommended.
So when we are doing intermittent auscultation, where do we usually listen on the belly for the baby's heartbeat?
We usually get the clearest sound over the baby's back. So if the baby's head down, that's usually in the lower part of the mom's belly. If it's breech, bottom first, then it's usually best heard around or above the belly button. And of course, as the baby moves down, that best listening spot will change. It's super important to feel the mom's pulse at the same time so you don't accidentally count her heartbeat instead of the baby's.
And how often should we be listening if it's a low-risk labor?
Once labor is active, we generally check the baby's heart rate and those contractions every 15 to 30 minutes. When the mom starts pushing, we do it more often, every 5 to 15 minutes. We also listen before and after vaginal exams, after the water breaks, anytime we give meds, and after the person walks around. Organizations like ACOG, WHO, and AFON, they all have good evidence-based guidelines on how often to check the fetal heart rate based on the risk level and the stage of labor.
Okay, let's get into the nitty-gritty of continuous electronic fetal monitoring. You talked about external and internal methods. What's the difference?
So external monitoring is what we call indirect. We use 2 sensors on the mom's belly held in place with belts. One is the tocotransducer, usually up on the top of the uterus, the fundus, and it picks up on the pressure changes from the contractions. The other sensor uses ultrasound and goes on the lower belly to monitor the baby's heartbeat. It looks at the baseline rate, any variability, and if there are accelerations or decelerations.
What are the good and bad things about external monitoring?
The good news is it's non-invasive, so we can use it even when the water hasn't broken and the cervix isn't dilated much. We get a continuous recording of the baby's heart rate, and we can see roughly how often and how long the contractions are. The downside is that it can limit how much the mom can move around, and it doesn't give us a totally accurate reading of those short-term changes in the baby's heart rate. Plus, sometimes the signal gets messed up, like if the mom is bigger, or the baby is moving a lot, or there's electrical interference, which we call artifact.
So what about internal monitoring?
Internal or direct monitoring is usually for when there's a higher risk for the mom or baby. For this, the water has to have broken, and the cervix needs to be dilated at least 2 centimeters, and the baby needs to be low enough for us to place the sensor. A doctor or midwife will put a tiny spiral electrode right onto the baby's presenting part, usually the scalp, to get a direct reading of the heartbeat. Sometimes they'll also put in an intrauterine pressure catheter, or IUPC, to measure how strong the contractions are, but nurses don't usually do that part.
What's the advantage of internal monitoring over external?
Internal monitoring gives us the most accurate heart rate reading because it's coming straight from the baby. We can see those tiny short-term variations in the heart rate and any little irregularities in the rhythm. Plus, it doesn't matter if the mom moves around, the signal stays clear.
So once we have this continuous data from the monitor, how do we figure out what it all means?
It's really important that any nurse taking care of a laboring person knows exactly how to read and document those electronic fetal monitoring strips and what to do based on what we're seeing in the whole situation. We're looking at a few main things. The baby's average heart rate, how much that baseline rate varies, any accelerations and any decelerations, whether they happen with the contractions or not. And we keep track of how these patterns change over time. Based on all that, we put the fetal heart rate pattern into one of 3 categories.
Okay, what are the categories?
So category 1, that's what we call a normal tracing. It means that at that moment, the baby's acid-base balance is probably fine, and we just need to keep monitoring routinely. Category 2 patterns are trickier. They're indeterminate. They don't necessarily mean something is wrong, but we definitely have to watch them closely and keep evaluating. Category 3, those are the abnormal ones. Those patterns tell us something is probably off with the baby's acid-base balance, and we need to act quickly. That might mean giving the mom oxygen, changing her position, stopping any labor-augmenting meds, or treating low blood pressure if that's an issue.
Can you give some examples of those Category 3 patterns that would make us worry?
Sure. Some big ones are fetal bradycardia, where the baby's heart rate stays below 110 beats per minute for a while. Recurring late decelerations, variable decelerations that either get worse over time or don't show any variability, and what we call a sinusoidal pattern, which is this smooth, wavy baseline.
You've mentioned baseline variability quite a bit. Why is that so important on the fetal heart rate tracing?
So baseline variability, that's how much the baby's heart rate goes up and down around the average. We look at the difference between the highest and lowest points over a minute, measured in beats per minute. Those little changes from beat to beat, that's the baby's parasympathetic and sympathetic nervous systems talking to each other. It means those 2 parts of the nervous system are working right, and the baby's probably getting enough oxygen. So when we see moderate variability, that's usually a good sign.
And what if there's no variability or very little? What could that mean?
If we see absent variability, meaning there's basically no change at all, or minimal variability, where it's less than 5 beats per minute, that can be a sign of fetal acidemia, often because the placenta isn't giving the baby enough oxygen or the umbilical cord is getting compressed. It can also happen with premature babies if the mom has low blood pressure, if the uterus is contracting too much with placental abruption, or if the baby has an irregular heartbeat. So what we would do is try to get more oxygen to the baby. We might put the mom on her side, give her more IV fluids, give her oxygen, and maybe even think about internal monitoring. Of course, we document everything and let the doctor or midwife know immediately. And if things don't get better, we might have to think about delivering the baby quickly.
What about when there's too much variability, those big swings?
So marked variability, that's when the fluctuations are over 25 beats per minute. That can happen if the umbilical cord suddenly gets compressed or prolapses, if the mom has low blood pressure, if the uterus is overstimulated, or if the placenta separates prematurely. Again, we try to figure out what's causing it and fix it. We'll put the mom on her side, give her more fluids and oxygen, and stop any oxytocin if she's getting that. We keep a close eye on the heart rate, maybe think about internal monitoring and let the doctor know. And if it doesn't get better, we might have to do a C-section.
You mentioned something important about external monitoring and variability.
Oh, yeah. It's really important to remember that those external monitors don't always show us the real variability of the baby's heart rate. So if we're using an external monitor and the baseline looks really smooth, like there's not much variation at all, we need to consider that it might not be accurate and talk to the doctor about maybe needing an internal monitor with the spiral electrode to get a better picture of how the baby's doing.
Let's move on to those changes in the heart rate that happen every now and then, the accelerations and decelerations.
Right, periodic baseline changes. They happen temporarily, usually in response to something like a contraction. Accelerations, those are those sudden jumps in the heart rate, at least 15 beats per minute above the baseline, and they last for at least 15 seconds but less than 2 minutes. Those are usually a good sign, often happening when the baby moves, and it means the sympathetic nervous system is working like it should. We don't usually need to do anything special when we see accelerations. In fact, they're one of the things we're looking for in a non-stress test.
Now, decelerations, that's when the heart rate drops. You mentioned early, late, and variable decelerations. How are those different?
So, early decelerations, they happen gradually and symmetrically, and they kind of mirror the contraction. The lowest point of the dip lines up with the strongest part of the contraction, and the heart rate is back to normal by the end of the contraction. They usually don't go down more than 30 to 40 beats per minute below the baseline. We think these happen because the baby's head is getting squeezed during the contraction, which raises the pressure inside their skull for a bit, and that triggers a reflex that slows down the heart rate. Early decelerations don't mean the baby's in trouble and we don't need to intervene.
What about late decelerations? What makes them different?
Late decelerations, they're also usually gradual and symmetrical, but they happen after the peak of the contraction. The heart rate goes back to normal after the contraction is over. These are linked to uteral placental insufficiency, meaning there's not enough blood flow and oxygen getting to the baby through the placenta. Lots of things can cause this, like low or high blood pressure in the mom, the placenta getting old, too many contractions, smoking, anemia, or heart problems in the mom. Late decelerations tell us the baby might not be getting enough oxygen. If they happen over and over, or even just once in a while, we classify them as either Category 2 or Category 3, meaning we have to do more assessments and maybe intervene.
What would we do if we saw those late decelerations, especially if it's a Category 3 pattern?
Category 3, with those repeating late decelerations, we have to move quickly. We call the doctor or midwife right away. If the mom is getting oxytocin to help labor along, we usually stop that to calm the uterus down. Then we try to get as much oxygen to the baby as possible. We'll change the mom's position, usually putting her on her side, maybe even on her hands and knees. We'll give her oxygen and more fluids through her 4V to boost her blood volume. And we try to figure out what might be causing the problem in the first place. We'll reassure the mom and maybe adjust how she's pushing if she's in that stage of labor. And we keep really good records of what we're doing and how the baby's heart rate changes. If things don't improve within about 30 minutes, we might have to think about delivering the baby quickly, maybe by C-section.
Now, variable decelerations, those sound like they're less predictable.
Yeah, they are. Variable decelerations are sudden drops in the heart rate, and they can look all kinds of ways on the monitor: U-shaped, V-shaped, W-shaped, you name it. And the key thing is they don't always happen in relation to the contractions. Usually they drop quickly and then go back to normal pretty fast. Variable decelerations are the most common type we see, and often they're not a big deal and we can fix them. Usually they happen because the umbilical cord is getting squeezed. Depending on the baseline variability and what else we're seeing on the monitor, we classify them as Category 2 or Category 3. If they always seem to happen with the contractions and they're slow to go back to normal, that's when we start to get concerned.
What about prolonged decelerations and that sinusoidal pattern? Those sound pretty scary.
So prolonged decelerations, those are those sudden drops of at least 15 beats per minute that last for more than 2 minutes but less than 10. The heart rate often gets really low, like under 90. These can happen because the cord is getting compressed for a while, or because of things like placental abruption, cord prolapse, the mom lying flat on her back, vaginal exams, taking samples from the baby's scalp, seizures in the mom, regional anesthesia, or even a tear in the uterus. The important thing is to figure out what's causing it and fix it as fast as we can.
And that sinusoidal pattern.
A sinusoidal pattern, that's a really distinctive one. It looks like these smooth, wavy lines on the monitor going up and down about 3 to 5 times a minute, and it goes on for at least 20 minutes. It's not very common, but it usually means something serious is going on with the baby, most often really bad hypoxia because the baby doesn't have enough red blood cells or enough blood volume. We always classify that as a Category 3, and we might need to do things like an intrauterine transfusion if we can. It's a sign that the baby is in real danger.
It sounds like seeing different heart rate patterns together can tell us a lot, too.
Absolutely. Those Category 2 and Category 3 patterns, they're even more worrisome if we see a few different ones at the same time, if they keep happening, or if we see lots of those prolonged decelerations, no variability in the baseline, a really high or low heart rate, or those prolonged variable decelerations where it drops below 60. And if those concerning patterns happen along with a loss of variability or with contractions that aren't normal, the chances of the baby having problems go way up.
Besides continuous monitoring, are there any other ways we can assess fetal well-being during labor?
Yep. If we're worried based on the heart rate patterns, we might do other tests. We can check the pH of the baby's blood from the umbilical cord right after they're born to see how their acid-base balance is doing. And in the past, we used to do fetal scalp stimulation, sometimes using a little vibrator, to see if the baby would respond with a faster heart rate, which would mean they're getting enough oxygen and their nervous system is working okay. But we don't do those scalp stimulations as much anymore because we're not sure how accurate they are, and they don't seem to lower the C-section rate. We might still use them in some cases, but not if the baby is preterm or if we think there's an infection or if the placenta is covering the cervix or if the mom has a fever.
Okay, so we've covered fetal assessment really well. Now let's move on to another super important topic. Making sure the person in labor is as comfortable as possible and managing pain.
Labor pain is something pretty much everyone experiences, although how bad it is and how people feel it is different for everybody. There are all these physical, emotional, social, and cultural factors that play into it. Even though labor is a natural thing, it can be really painful. The pain comes from the cervix stretching as it opens, the muscles in the uterus not getting enough oxygen during contractions, the baby pushing on things like the bladder and rectum as it moves down, and all the muscles and tissues in the pelvic floor getting stretched.
It's not just physical, though, right? There's a big mental and emotional component, too.
Oh, absolutely. A woman's past experiences with pain, how tired she is, how anxious or scared she is about giving birth, how good her support system is, the environment she's in, and even her cultural beliefs all affect how she feels and deals with the pain of labor. Plus, the pain itself changes as labor progresses, and that often changes how she acts and how well her coping mechanisms work.
You mentioned culture. How does that impact how we handle pain management?
The way people show they're in pain and what kind of pain relief they want during labor can be really different depending on their culture. We have to be aware of those differences. We might need to get a good interpreter, offer different methods of comfort and pain relief that are acceptable to that person's culture, and make sure we're checking in with her about her pain in a way that respects her beliefs and values. It's all about being culturally competent.
So we have two main ways to manage pain during labor: nonpharmacologic and pharmacologic.
Exactly. Pharmacologic means using meds to relieve the actual feeling of pain. And non-pharmacologic means helping the person cope with the pain and making them more comfortable using different physical and mental techniques. We can use them separately or together, depending on what the person wants and what's going on medically. The nurse's job is to explain all the options clearly and fairly, and to respect the person's choice about how much pain relief they want and what method they prefer. And we can't forget that hospitals have to follow rules about assessing pain for all their patients, and that includes people in labor.
Let's talk about the non-pharmacologic options first. What are some of the main strategies?
A lot of non-pharmacologic pain relief is based on the gate control theory of pain, which basically says that if you stimulate certain non-pain nerves in the body, it can actually block or lessen those pain signals going to the brain. We usually try these methods first because they're generally considered safe, easy to do, and don't cost a lot. A lot of these techniques are taught in childbirth classes, and it's a good idea to practice them ahead of time with a partner or support person. As nurses, our main job is to encourage, guide, and be there to help practically. These methods can really help the laboring person feel more in control.
Can you give some examples of those non-pharmacologic comfort measures that really work?
Continuous labor support is a big one. That means having someone dedicated to supporting the person in labor. Could be a partner, family member, doula, or a nurse who's there the whole time to offer emotional support, comfort, and information, and to advocate for the person's wishes. There's a lot of research showing that this can make people need less pain medication and even lower the C-section rate. Hydrotherapy, like showers or baths, can also be really helpful for a lot of people as long as the pregnancy is healthy. Moving around and changing positions often is super important too. Back in the day, women used to labor in all sorts of positions, and now research is showing that walking and being upright during early labor can even help shorten labor without making interventions more likely. Changing positions every 30 minutes or so helps with the pain and can even help labor progress by using gravity and helping the baby get in a better position.
What about things like acupuncture and massage? Do those have a place in labor pain management?
Acupuncture and acupressure seem to help some people with pain relief, but we need more research to be sure. Some studies show that people who use these techniques feel more satisfied with their labor experience and need less pain medication. Massage, including a technique called effleurage, which is lightly stroking the belly in time with the breath, can also be really comforting and relaxing. Massage can help the body release endorphins, those natural pain relievers, and just the feeling of touch can block some of those pain signals. Breathing techniques are also really helpful, like the patterned paced breathing they teach in childbirth classes. Those techniques can help you relax, feel more in control, and make sure you and the baby are getting enough oxygen. And sometimes, something as simple as putting heat or cold on different parts of the body can make a big difference. Heat can relax those tense muscles, and cold can numb the nerves that send pain signals. Then there are those mental techniques, like focusing your attention and using imagery, which can help take your mind off the pain.
Wow, it feels like there's a whole toolbox of non-pharmacologic options nurses can use to help people during labor. Now let's talk about the pain meds.
Right, pharmacologic methods. The main goal here is to give enough pain relief to make the person comfortable while making sure both mom and baby are safe. We have two main types of pain meds: systemic analgesia, which affects the whole body, and regional or local anesthesia, which numbs a specific area. Neuraxial analgesia, like epidurals and spinals, those are really popular and effective for a lot of people.
Let's start with systemic analgesia. What kinds of medications do we use for that?
The systemic analgesics are usually given by mouth, injection into the muscle, or IV. They include opioids, antiemetics, and benzodiazepines. Opioids like morphine, meperidine, fentanyl, butorphanol, and nalbuphine, they can help with the pain, but they can also cause breathing problems for both mom and baby, especially if they're given close to delivery. We often give antiemetics along with opioids to help with nausea and vomiting, and they can also make you a little sleepy. Benzodiazepines are kind of tranquilizers. They can help calm you down, and we might use them in certain cases, like if the mom is having seizures from eclampsia or she's really anxious. It's important to remember that all these meds cross the placenta and can affect the baby.
You mentioned something about inhaled analgesics, too. What's that all about?
Oh yeah, nitrous oxide. That's laughing gas.
Yeah.
We mix it half and half with oxygen, and it's becoming more and more common here in the U.S. The person in labor breathes it in through a mask or mouthpiece as needed during contractions. It's pretty safe and effective for most people, and a lot of women like that. It gives them a sense of control. Side effects are usually not a big deal and don't happen often, and we haven't seen any problems with the baby's heart rate from it.
Okay, let's move on to regional analgesia and anesthesia. That includes epidurals and spinals, right?
Exactly. Regional anesthesia numbs a specific part of the body without putting you to sleep. We use local anesthetics, sometimes with opioids too, to block the nerves in the spinal cord and the nerves coming out of it. For labor and delivery, we're usually targeting the nerves below a certain point in the lower back. The main types we use are epidurals, combined spinal epidurals, CSE, local infiltration, pudendal nerve blocks, and spinals, intrathecal. Epidurals and spinals are the common ones for labor and delivery pain, while we usually use local infiltration and pudendal blocks for things like episiotomies or stitching up tears after birth. The great thing about regional anesthesia is that a lot of times the person can still participate in the birth even though they have good pain control.
Epidurals are pretty popular for pain relief during labor. How do they work?
So with an epidural, we inject a local anesthetic, usually mixed with an opioid, into the epidural space in the lower back. It goes in through a thin tube called a catheter, and that stays in place so we can keep giving meds as needed throughout labor. Epidurals are really good at controlling pain, but they can sometimes make the pushing stage last longer, and they might make it more likely that we'll need to use forceps or a vacuum or give oxytocin to help labor along. There are some cases when.